Great, I'm going to go ahead and get started. Although for some reason my PowerPoint is not at the beginning. There we go. Great. So when I do presenter view like this, I cannot see any of your faces if you are using your video. So use audio to interrupt me if you have a question, or you can write it in the chat as well. Like I said, I can't actually see anybody when I do it this way. So today's presentation is about implicit bias in healthcare. It can be a really frustrating topic that might bring up some feelings of anger or personal experiences of bias that you might have experienced. So I kind of wanted to have everybody be a little prepared for that today, and hopefully you're in the right mental space to be able to do that. And this presentation was created by one of my social work trainees, Carmen, and she did a really excellent job. So she and I worked together on this to give you a good introduction to this topic, which I think is, although can be very frustrating to learn about, is also just really important. So our objectives today are to be able to define implicit bias, identify how it's manifesting in healthcare settings with our patient populations here at Neon, and discuss strategies for how to change it, because I think that part's really important. All right, so what is implicit bias? I'm not sure how many people are familiar with that concept. I think we all know what bias is. It's assumptions or stereotypes, jumping to conclusions about a certain group of people. And you can have both a favorable bias. You can be biased positively towards someone because they belong to a certain group, or you can be biased negatively or unfavorably towards someone because they belong to a certain group. And the whole point about implicit bias is that it happens involuntarily and outside of our awareness. So explicit bias, in contrast, is when you think, oh, this person belongs to this group. I don't like that group, or I have these negative beliefs about that group, and therefore I'm going to treat this person differently. It's very conscious. It might not be that obvious, but it is a conscious decision when you have explicit bias. Implicit bias is happening outside of your awareness. You're just like, I really like this person, or I don't really like this person. I don't want to talk with them, based off of everything that we're going to talk about, but you're not really aware of that influence. And this is related to these ideas of systems of thinking, that there are two systems of thinking that we use. System one is what we think of as like instinct, gut instinct, or anything that we think of as being like automatic. Whereas system two thinking is slower, rational, more logical, effortful. And that's what we are normally relying on when we think about, oh, I need to make a decision about something. When you think about that, you think about system two thinking. But we often make decisions using system one thinking. And you can't stop doing that. We need system one thinking. I do not have the time or the energy to sit and do system two thinking for every single decision that we make. We have to operate instinctively and with automatic, little or no efforts, unconsciously. That's not going to change. What can change is our awareness of how that system might be biased, and efforts to change that. I think it's really important to note that sometimes there is a bias that is just very general, like a discomfort or a dislike or a disgust related to a certain group of people. And sometimes it's more specific. Like, I believe this a stereotype we're going to talk about today, a bias we're going to talk about today, is that that I think comes up in one of my examples later, is that Black men are more violent or more prone to crime. I think we talk about that in the video later. So that is a bias that people might have. And that's kind of a more specific bias that might come up in your thinking versus something that's just more general, like I'm uncomfortable with this group of people, or I don't like being around them. So I think we can move on from that.
Implicit bias.
So we're gonna watch a video now that covers implicit bias really well. Can people hear it? Can someone tell me whether or not you heard that? And I need audio because I can't see people's faces.
Implicit bias.
Can people hear that?
Yes, I heard it.
Okay, thank you. So I'll go ahead and play it and hopefully people will be able to hear it.
Implicit bias.
2016 was the year that implicit bias went somewhat mainstream.
Yeah, so when Hillary Clinton mentioned implicit bias in the debates, our phones started blowing up, all our friends started emailing us about it.
But what is implicit bias? Implicit biases are basically thought processes that happen without you even knowing it. Little mental shortcuts that hold judgments you might not agree with. And sometimes those shortcuts are based on race. First, some clarity. Saying someone has an implicit bias is different from calling someone a racist.
The word racist is a highly loaded term, right, here in American society. A lot of times when people are using it, they're thinking of the kind of old-fashioned Ku Klux Klan style racist.
But implicit bias isn't anywhere near that, explicit.
Implicit bias is something that comes out of ordinary mental functioning, out of how the mind normally works.
We've all grown up in a culture with media images, news images, conversations we heard at home, our education. Think of that as a fog we've been breathing our whole life. We never even realized it, what we were taking in.
And that fog causes associations that lead to biases.
I somehow know that if you say peanut butter, I'm going to say jelly. That's an association that's been ingrained in me because throughout my life, peanut butter and jelly are together. And in many forms of media, there's an overrepresentation of Black men and violent crime being paired together.
And because of that, I actually deep down inside have been taught that Black men are violent and aggressive and not to be trusted, that they're criminals, that they're thugs.
With all those associations, I'm not trying to let us off the hook, but in some ways, none of us stood a chance.
Starting today, we'll post a video a day dealing with one challenge of understanding implicit bias.
So I think that video, I like how it kind of explains the idea of the associations. That you pair something together enough time, peanut butter and jelly, biased beliefs about any specific group, we can't help but associate them. I do disagree with one thing the video says. So the video says that this is different from racism. It's not. It's all racism, but it is a different way that racism manifests itself because racism can show up in a lot of different ways. So this is one way that racism shows up versus some more explicit beliefs or structural racism. But I don't think it's appropriate to say that it's not racism to have implicit bias. It is. It's just a different way that it shows up in our lives. Right. So talking a little bit more about how this actually works and operates. This is pervasive. So we often have, as a culture or a society, similar biases because we all grew up, like they said, breathing that same fog. But it varies person to person. So some people have more implicit bias than others, and some people may have an opposite bias than the majority. So it's not like everybody has the same amount of bias or it looks exactly the same. We know that implicit bias impacts real world behavior. So even though you don't know that it's occurring, that it's happening kind of automatically and outside your awareness, it does impact the way that we behave and the way that we make choices and decisions and the way that we treat people. So it matters. And like we said, you're unaware of it, even, there's different ways that we're able to test implicit bias that I don't want to get too into, but a lot of people don't think they have implicit bias when they do. Like that's very, very normal. And that doesn't mean that people are lying necessarily. It's more that people are not aware. And it can go counter to our conscious beliefs. So you might believe and explicitly say that I have a favorable attitude towards this group. I have no problem with this group of people, whether it's LGBT people or a racial or ethnic minority group or women, or people who are economically disadvantaged, people who are disabled, any sort of group that we're talking about. You may feel, and it might be really important to you even, that I have positive feelings towards this group. I'm not biased towards them, and that's very important to me. And you might still have implicit bias. Those absolutely go hand in hand, is that you can explicitly feel very positively and implicitly have a negative bias. Interestingly and disturbingly, research shows that implicit bias can be a better reference for behavior, a better predictor of behavior, I should say, than explicit bias. So it often is driving our choices even more, which is another reason why it's important to be aware of it. And it's common to have implicit bias against certain groups because of the culture that we live in. So because we live in a racist culture, when you do large studies of implicit bias, you find that a lot of people are biased against Black people as well as Latino people. And unsurprisingly, when you look at doctors and medical providers, you see similar rates of implicit bias. So medical providers are biased towards racial and ethnic minorities on average, the same way that our entire society shares some of those biases. And patients are aware of that. And so there actually is research that when you look at, 2 or 3 different medical providers, you have one medical provider that's neutral, one medical provider that's positive, one medical provider that has negative and bias towards a racial or ethnic minority patient, that when you ask patients afterwards about their interactions with those providers, they rate the biased provider more negatively. So it comes through in the way that we communicate with people, even if we are not aware of it and deny it. So how does it impact healthcare? On multiple levels, right? Because it's literally the way we're thinking. So we have bias that impacts our perception of the patient, of the problem, of what they're saying. And it impacts our diagnosis, communication, health outcomes, decision-making, all of it. And so I'm going to give some specific examples of that. So when you prime medical providers with Black faces, so what that means is that you show medical providers a lot of pictures of Black faces, which gets them thinking about Black people and Black skin. And then you ask them questions about a patient and saying, what do you think this patient might be diagnosed with? What do you think their problem is? They are much more likely to think about drug use as being the explanation for the patient's problem when they have recently been shown Black faces versus when they've recently been shown white faces, because there's an implicit bias, an implicit association between Blackness and drug use, which not only is racist, but really importantly is also extremely inaccurate when it comes to what we see in the population in terms of substance use is equally distributed across racial and ethnic groups. So it is not an accurate perception. So it's really going to bias the way that you may think about patients. And it goes both ways, right? Providers might be more likely to diagnose substance use or think about substance use for Black patients when it maybe isn't appropriate. But they also, I would argue, are missing a lot of substance use in white patients because they aren't making that association. So again, it can bias you in a number of different ways. I have a couple of other quick examples. I'm trying to think about if I have time. We talked about that one. And there's also a lot of research on opiate prescriptions and how opiate prescriptions, even before a lot of the changes that have been happening recently with them being more restricted and less prescribed, that Black patients have been prescribed less opiates on average, consistently across the board. And that is related to implicit bias and a belief that Black patients don't experience as much pain as white people, or that they don't deserve their pain to be treated as much as white patients, resulting in more opioid prescriptions for white patients compared to Black patients, which has obviously had different impacts down the line. So these are all ways that implicit bias can impact our care. And we're going to go through even more examples because I find the examples really helpful. So there is research about how this impacts specialist referrals. And a lot of my examples today do focus about bias against Black men and women because of our patient population. I think that's really important to talk about. But I will talk about some other examples as well, because implicit bias can refer to attitudes towards any group of people. It moved. So the specialist referrals, there's research that providers who have more implicit bias compared to less implicit bias were less likely to refer Black patients who presented with chest pain to a specialist when they were rushed. So let's walk through this, right? So there's some sort of implicit bias, and all we know about implicit bias is there's some negative association. And I'll talk a little bit more about that later, hopefully if I have time. There's some negative association about some belief that's automatically happening and occurring. Maybe it's that Black patients are less important or less trustworthy or less worth my time compared to the white patients. And this leads to a perception that, like, we don't need to worry about this. This isn't that big of a deal. Less severe diagnosis, which maybe you ask less questions, less thorough history. And ultimately what this study found is less likely to place that referral for cardiology. It might also impact your communication, like that study I talked about, where the implicit bias, patients can pick up on that. And there's actually studies that show we can see implicit bias, individual differences, implicit bias. Someone who is more implicitly biased will make less eye contact, spend less time with the patient, less likely to use words like we when talking about treatment planning, like, we're going to make a plan for this. We're going to address your chest pain. And then there can be really some serious health outcomes that I feel like I don't really need to explain, right? It's like, if we're not placing referrals, people aren't getting diagnosed. They might end up dying from conditions because they don't know that they have them and didn't get the specialist treatment that they need. Patients might just avoid healthcare because they have uncomfortable experiences with their providers, or patients might feel like this is fine, right? Like, I went to my doctor and I had chest pain. Doctor said it was fine. I didn't need to see a specialist. So now I'm not going to worry about it, when really it was something that maybe they did need to worry about. Another example is women and coronary heart disease. There is a lot of evidence about how doctors provide different care to women who present with symptoms of coronary heart disease compared to men. They believe that some of this bias is that medical training focuses on men's symptoms of coronary heart disease. And the bias might also just be that we have to dismiss women's symptoms as being less serious because they're just anxious or upset and it's not that bad. Or it could even just be that providers have an implicit bias towards not wanting to spend as much time talking to women or not enjoying those conversations as much and preferring to do that with their male patients. So whatever that bias is, it leads to those different perceptions versus, oh no, this is serious, or I don't know, the pain doesn't seem that bad. Leads to different diagnoses, leads to different decision-making, maybe less tests, less physical examinations was a result of a different study that I read, that they're less likely to do physical examinations with women who are presenting with the same symptoms, less medication, less communication of concern, like, I'm really worried about you. This is something that we really need to be taking care of. And the same kind of health outcomes we were talking about before. That's pretty much going to be the same through everything we talk about. Missed, delayed diagnosis, avoidance of healthcare, minimizing symptoms. All right, example number 3, lesbian, gay, and bisexual patients. So there is less research on this. I had some trouble finding some good research on this, especially compared to implicit racism. So implicit bias against sexual minorities is extremely common among healthcare providers. So there is a lot of research documenting that. Just like racism, if you see it in the community, you're going to see it in medical providers. So that bias is discomfort, dislike, maybe even disgust. And when that bias is there, they're unconsciously projecting that onto patients. And patients might say, or providers might feel like, I don't like them. I don't want to spend time with them. I feel uncomfortable talking to them. And not feel like, oh, I don't like them because they're gay. I just, feel like I need to get through this appointment. This is not my favorite patient. And this can have a variety of consequences that we've already talked about, right? It's going to affect that decision-making, the communication, and the outcomes. There is an abundance of evidence that LGBT people in particular avoid healthcare because of negative experiences, which leads to so many poorer health outcomes. So a lot of people don't feel comfortable going to medical providers who are gay because of this implicit bias. I think definitely plays a role in that because patients can tell when we feel bias towards them, even if we don't know what's happening. I wanted to talk about patients who use drugs because obviously here I work in the MAT program, and I think it's an example we don't talk about as much when it comes to bias, but there is a lot of bias against people who use drugs, and that could be explicit. You can explicitly believe that people who use drugs are untrustworthy or deserve to be punished, or maybe you don't, but implicitly there's a lot of association there. Drug use, bad. People who use drugs, bad. When you have those associations, and there is specific research on associations about deserving to be punished, so that providers feel like people who use drugs deserve to be punished for their behavior, whereas people don't feel like patients with diabetes need to be punished for not managing their diabetes. We feel like people who use drugs need to be punished for using drugs in their addiction. So that is going to influence our perception in that we tend to see these patients as more manipulative, untrustworthy. We want to come down on them. We want to be strict because you think they deserve punishment. When you have that association, you might notice that with your patients who use drugs, your attitude is a little bit different than it is with other patients. That's something to pay attention to. Again, some of that same consequences. You might diagnostically, you might be kind of biased thinking that everything is about their drug use, and you might be missing something that they're experiencing that is not connected to their drug use at all, because all you can see is that drug use. And you might just feel less close to these patients, right? And I want to say that it is normal to have different reactions and different levels of closeness, different levels of comfort with all of our patients. That is normal. That is human. We're not saying that you should feel the exact same way about every single patient or every single type of patient. But what I'm saying is that we should be aware of where some of those feelings might come from, and that they might come from bias that comes from racism, sexism, homophobia in our culture broadly. So there's this quote from this research study about people who use drugs, about how they feel like medical providers view them, that I think is something a lot of my patients have said, that they feel like sometimes even here at Neon, they feel this way with our staff or our doctors. And I'm going to read it so that we can all experience it. They look at us like junkies, but you know what? This junkie right here bleeds the way you bleed, has feelings the way you have feelings, loves the way you love, hate the way you hate, hold grudges the way you hold grudges, walk the same way you walk. These providers are so judgmental, they would literally come out and speak about you behind your back. So when we're having a lot of explicit bias and or implicit bias, really either one, we tend to treat people as stereotypes rather than as individuals. We're seeing them just as someone who uses drugs, or just as someone who's from a racial or ethnic minority group, rather than seeing them as an individual with complexity. Looking at my notes. I also wanted to add that another way that this comes up for people who use drugs is there's a lot of research about how the language we use changes the way we think about patients. So when you say addict, people tend to feel more negatively about a patient and want to judge them more or want to deny them care. Versus when you say someone with a substance use disorder, people tend to have more empathy. And I think it's a great example of how the language we use about our patients can lead us to have more bias or less bias. The language we use matters. All right, so can we change our implicit bias? Yes, we absolutely can. The research is clear on that. The research is also clear that it's not easy. It's going to require humility. And I want to say that it requires that we desire to change. There are people out there who have explicit bias and implicit bias. There are providers who are racist and don't want to change that, or are homophobic and don't want to change that. So will those people change? No. But if we desire to change, if we're willing to practice, because you need to create new associations and that takes time, if you acknowledge that it's powerful, right? That this is a big thing that's happening in your brain, and that it's having a big impact on the decisions that you make, and you commit yourself to learning, I do think that we can change. How do we do that? Explicit strategies right here. One is taking this time to learn, right? Explore your own implicit biases. I'm going to show you a test, and I'm going to email out the test that you can do to see what kind of implicit biases you have. It's a free implicit bias test that you can take online. And so that's one way, figure out what kind of bias you have through tests or through reflection. One is mindfulness. So we want to be connecting with reducing our stress, connecting to the present moment. If we're rushed, we tend to rely more on system one thinking. That's why that study found that effect about bias and specialty referrals. It only occurred when providers were rushed. So even biased providers, when they aren't rushed, they use system two thinking and they provide the same care to patients in that study. But when they're rushed, that's when the bias kicks in and they don't provide the same type of care to different patients. So learning how to manage stress and be more mindful and slow down are all ways to help us not rely on implicit bias so much by slowing down that system one thinking. You also want to practice perspective taking. You want to read books, be exposed to different cultures, watch videos, learn to know this group that you have bias about, have experiences and communication with people from that group so that you can start to understand some of their perspective and their experiences and have more empathy instead of seeing people as a stereotype. And the only way to do that is really through experience. And I think going along with that is individuation. So moving past that automatic bias of this person is a stereotype, which is automatic. And again, we can't stop that. We're always going to see people as a stereotype of some kind. We're going to have associations right away. We're never going to stop that. But if we work on, those are my associations, but this person in front of me is an individual. So I have these associations and I'm aware this person is an individual and my associations may or may not apply. And practicing that can help as well. Also, we need systemic change to stop implicit bias. We need to, although I didn't say this earlier and I need to, it is not only possible, but common for people to have implicit bias towards their own identity groups. So for gay people to have implicit bias against gay people, for Black people to have implicit bias against Black people, for women to have implicit bias against women. That is all possible and even common because, again, we all breathe the same air in our culture, but it is usually less common to have those types of implicit biases for people who belong to that group because, they're more aware of some of the things that we talked about, aware of the stereotypes and seeing people as individuals. So the more providers we have from marginalized communities, the less bias we will have. And we can train people like we're doing right now. That can help, especially during medical school, getting people early. And we can reduce cognitive load. Again, in stressful, high-paced environments, people rely on system one thinking and use bias more. So if we can create environments where providers are less overwhelmed, they'll be less likely to make those types of assumptions. I also think it's really important that we track outcomes and hold people and institutions accountable. Look at your specialty referrals, look at your diagnoses. Make sure that there are not populations that are systematically being treated differently. And we can do that. We have a lot of data now that we can pay attention to those things. All right, so the website that I'm going to send out is it's called the IAT, Implicit Association Test. I actually used one in my dissertation. And you can take a bunch of different types. There's one for race, weight, gender identity, so for transgender people, age, sexuality, skin tone, religion. different ethnic groups like Asian American or Arab Muslim American, disability status. So if you want to find out if you have implicitly negative association, you can take those tests. And basically what it does is that if your brain is really good at linking Black faces to the word good, then you have a positive bias towards Black faces. If your brain is a little bit slower at linking Black faces to the word good, you might have some bias. It's as simple as that. And that's how the test works. If you get a test result that shows that you're biased, remember that you're not alone. I definitely got and still do get biased results when I take these implicit attitude tests. And although that can be scary and embarrassing, it also is really helpful and motivating to remember that we can all grow and we all should be growing in the way that we view other groups. And to be aware of, if you're having a result on this test, that's also how you're reacting to a patient in front of you. Your brain is making those same associations. So this is, I think, what we were talking about. We're all guilty of implicit bias. Nobody is immune. And we want to understand how it creeps in and impacts patient care so that we can do better. And again, I want to really normalize this. I have made lots of implicit bias errors with my patients. I've assumed that patients who are homeless are not educated without asking them. I have assumed that one thing I've noticed is that I don't ask older women, I don't ask them about drug and alcohol abuses frequently. I forget to ask that question. And so I think that I have some associations about that group compared to other groups that, again, really aren't appropriate and aren't helpful. So it can come up in so many different ways. And we just need to be aware of it so that we can make changes. Another one that I really noticed in myself recently is that when working with geriatric patients and older adults, I might be, it's important to be aware of cognitive concerns that go along with aging, but sometimes I think I'm jumping to that too quickly and, making assumptions about somebody's cognitive functioning because of their age. That is a bias that I need to work on when working with my patients. So those are some of the things I've noticed just recently for myself with bias, and I hope that you all can learn some of those things too. All right, I'm going to stop sharing so that I can see people's faces. I know you might have to get to lunch, and I went a little over, so please, you need to go. If anyone wants to comment or chat, I am here to do those things as well. Thank you all for coming. I appreciate it. I will take another picture now for attendance so that if anybody came late, I still catch them. Oh, let me stop the recording.